I'd like to welcome everyone to our Ontario Health Team Stories from the Field HSPN webinar. We have a great lineup today. If you're joining us now, please let us know who you are by introducing your name and your OHT or other organization into the chat. Please be sure to send it to everyone, not just the panelists in the chat. Hello, Laura from OH West. Caitlin Brandon from the Regional Geriatric Program. Ann Boytak, Laura Daly, Brent McLeod, Eric from Algoma, Christina Clark from one of our coaches, Lisa Salpanek, not sure I said that quite. Bonjour, Elizabeth Cote Wallo from KW4, Dula from Downtown East. Oh, this is when they come super fast. Here they come flying in, 150 people online already in just a few moments of the opening of this webinar. Welcome everyone. Amber from Middlesex, Nazira Jaffer from Yihong, Miriam, Community Respiratory Therapy from several OHTs, Anthony Scittini, a patient partner from Central West OHT. Welcome. Well, really, really excited today to have all of you here, and it's going to be a very, very lively session today. We have many, many people joining us. The first thing that we always start with here is to acknowledge the land on which we work. And I speak to you today from the University of Toronto, and the land on which the University of Toronto operates for thousands of years has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, the meeting place is still the home to many Indigenous people from across Turtle Island. And I and we are grateful to have the opportunity to work on this land. I welcome you from across the province and wherever you may be joining us from to recognize the land and the territories and the traditional uses of those territories and lands on which you are joining us from. Welcome. First thing we like to do is to have a poll and get you engaged for the first time and see if this is your first time in joining us. So let us know if this is the first time that you've joined us. Okay, we're going to end the poll and share out the results. So here we are. You see that over 100 people. This is their first. This is not the first event. You joined us previously, and almost 40 people again. It amazes me that we continue every time. 28% of our audience today. It's the first time you're joining us. So welcome. You are in for a treat. You've picked a great time to start. Okay, and so first I want to introduce you to some of the people that are going to be speaking today in various forms. We are going to start off with the Patient and Family Health Council from the North York Toronto Health Partners. And you see all of the members represented there. We're also joined by Emily Doxeter and Ivy Wong, who are from the Strategic Initiatives branch, and they support all of the work that you see in North York, Toronto, and particularly the Patient and Family Health Council. We are then going to hear from Jeff Wingard and Melissa McCallum from the Greater Hamilton Health Network. And Gaya Embuldeniya is our embedded evaluator with that team, and she'll be providing some introductory remarks and comments. And they're going to speak about governance. And finally, Melissa Sharpe-Harrigan from the Chatham Kent Ontario Health Team is going to speak about their work in strategic planning. And Kaileah McKellar, who's our embedded evaluator there, will also be introducing them. So we have many, many people. You are actually going to hear all of these voices today. So I won't belabor the introductions too long. Because some of you may not have been at our last month's first Stories from the Field, I'm just going to provide just a quick overview of how we came to know these teams. The Health System Performance Network is involved in a developmental evaluation, which involves real-time feedback and learning about what is emerging in the complex dynamic systems that are OHTs. And we are observing teams and providing feedback on dimensions of the Ontario Health Team development. And these can include a whole array of different aspects of development of the teams, thinking about resources, governance, leadership, communication, digital health, population health management, and others. And you'll see that we bring these stories to the broad population of all Ontario Health teams and other interested individuals who may be interested in seeing how this initiative is evolving. And this is our way of sharing out what we learn from our deep dive into the teams. The teams that we're working with, first, All Nations Health Partners. We're also working with East York Region and North Durham. Today, you'll hear from Chatham Kent. Last month, you heard from Couchiching and North York Toronto Health Partners in Greater Hamilton. So you'll see that we have looked for urban and rural and remote and Indigenous representation. We considered the settings, the focus populations, and some other characteristics, and the willingness of these teams to engage with us. It is not without effort that these teams are working with us on this evaluation together as a joint endeavor. So we're really pleased to be able to bring some of these stories from these teams more broadly. This is the team that's working out with the OHTs on this developmental evaluation. I have the pleasure of working with the North York Toronto Health Partners, and I'm going to introduce today a little bit about the Patient and Family Health Council. I've been observing in North York Toronto from a few different perspectives. First off, their overall group, their core group, as they call it, meets every Thursday morning at 8 a.m. And then also the backbone team, which meets Mondays, following that group's team, as they support all the work across the Ontario Health team. But mostly I've been spending a lot of my time with the Patient and Family Health Council. This group has really amazed me in so many ways. First off, what amazes me is how they permeate the entire Ontario Health Team initiative. And they are involved in all of the working groups and all of the teams across the network. Second, so actually by going to their meetings, you can find out what's happening in all of the team, which is pretty amazing. Second is that they really feel a part of the team and that they are really have a core role in the Ontario Health team. And I think I see it in the other teams, like really paying attention to what the patients and family, or all the committees, what the patients and family members are saying. They co-developed the entire patient-family engagement approach that the team is undertaking. And they are not shy. I've even seen them call out the senior leaders to say, why weren't we involved in that decision? We need to be in every decision. And so I think they really embody what it is to be very involved. And the IAP2, this is from the UK, the International Association for Public Participation, talk about the different ways that people can be involved. Now, this is mostly thought about from the public, but can also be thought about in the engagement of patients and caregivers, leading from informing to consulting, to involving, to truly collaborating, and finally to empower across the network. And I find that in North York, I'm really seeing a deep sense of collaboration where the patients and family are partners in each aspect of the decision making, including the development of alternatives and identification of preferred solutions. They're really part of the whole system. So that's why we're bringing them here today to talk to you. As I mentioned, this is the entire council, and they have prepared for us today a video so that we can hear all of them speak about their experience, and then we'll open it up to Q&A. So without further ado.
Hi, my name is Wendy Wu. Thanks to Walter for inviting us to this webinar. As each OHT team explore different ways of integrating, improve the integration of our healthcare, I think story from the field is a great way for us to learn from each other. Today, we're going to share with you how our group evolved. Our OHT is composed of 21 core partners, 30 plus alliances partners with Primary Care Association and Patient and Caregiver Health Council. Together, we support just over 500,000 population. And we adopted collective impact working model, and we're supported by a backbone team that is composed of some funded resources and some in-kind resources from our partner organization. Our journey started in January 2019. Some of us was brought in from our partner organization's PFAC group to help with the application. In December that year, we were officially designated as an OHT. In February 2020, we had a symposium, and that basically set the foundation of our partnership. Out of that, we had launched Compassionate North York, which is our vision. In March, we're in lockdown. However, it did not deter us. If anything, it catapulted us into a greater sense of urgency with the pandemic. And we also understood the implication it came with. I think we stepped up to the challenge and worked hard with our partners to support the community. This allowed us to gel as a team, and we formalized our group as a patient and caregiver health council in September last year. Out of wave one, we regrouped and we had a retreat, identified about 20 plus projects we are moving forward with. In March this year, the urgent call to help roll out the vaccination in our community came. And our OHT stepped up to the challenge and responded in full force again. I have to say, our work to support the pandemic is commendable, but it did cause some delay in the overall progress of our team. We just had another retreat in September, and right now we're focused on finalizing our governance structure and our strategic plan. Over to you, Judy.
Thank you, Wendy. The current members of the PCHC come from various backgrounds. Wendy served as a patient caregiver advocate with Yi Hong while acting as a caregiver for her in-laws. Ron acted as a caregiver for his father and is a well-known advisor for many organizations, as well as being a great IT resource. Rivka is a client family partner from Baycrest after retiring as a school administrator. Min Wang worked at North York General and is currently caregiver for her parents. Kim has served in the Family Council at Seniors Health Center, where her husband is a resident. She also currently has parents in Moncheong Long-Term Care Center, and Leela and I both served as PFAs with North York General Hospital after acting as caregivers for our parents. This diversity of backgrounds gives our PCHC the needed perspectives for us to function most effectively. Over the past couple of years, we have had others serving with us, but for personal reasons, they've had to take a break. Hopefully, once they are able, they will again join us. Instrumental in the work we do are the contributions from our backbone team. Currently, Emily Dockstader, Yinka McCauley, and Ivy Wong. We were also fortunate to have help from Diana Raymond Watts and James Shembry, who have both moved on to other OHTs. Shauna Haberman, the patient and family-centered care consultant at North York General, has also given us direction based on her expertise. To strengthen the work we do, we are all active in learning through webinars, conferences, and courses put on by RISE, OCO, IFIC, and other organizations. This slide shows our fun side. Our group aren't just colleagues. We have become friends and operate as a team. We respect and support each other to bring the patient, family, and caregiver voice to all the work we do. We share the same passion, and through NYTHP, we have bonded and stand by each other and our community. The further we get into this process, our friendship and support for each other and our commitment have deepened and strengthened. Thank you. And now Ron will speak.
Thanks, Judy. Now, this table shows the key North York Toronto Health Partners initiatives we are involved in as Patient and Caregiver Health Council members. We are engaged early in projects and initiatives to provide our support and input. Our members can contribute as much or as little time as desired based on their schedules. Members choose the initiatives in which they are most interested in. For example, Kim has chosen to be the ambassador for the North York Toronto Health Partners to lead the caregiver campaign. And you can see how varied members are able to contribute their time. Since we are involved in all key initiatives, we have a pulse on the North York Toronto Health Partners as a whole. However, it is very time consuming, and currently we do not have enough resources to sustain this level of work and engagement. Now I'll pass it over to Min.
Thanks, Ron. We have a 90 minutes team meeting every 2 weeks. Since we got to know each other better and we are comfortable voice our opinion, the biggest hurdle is to finish the meeting on time. The meeting agenda is planned 2 to 3 months ahead, with pre-meeting reading material distributed 3 to 4 days before. All meetings follow a set structure, starting with the check-ins and stewardship console update. This allows members to share individual updates. Then we either working on issues or invite other NYTHP leads for more detailed updates. All meeting wrap with summary of actions on upcoming agenda. Minutes will be saved on Google Drive and distributed 2 to 3 days later. We are still refining our process. For example, to use a standard template for presenter to summarize their messages and needs from us. Now I hand over to Kim. Thank you.
Thank you, Min. It's my pleasure to speak to you on what we did well. COVID-19 is front and center for OHTs, and it's no different for North York Toronto Health Partners. Our members provided support for COVID-19 response by volunteering, by planning webinars, by translating promotional materials, by reaching out to community groups, and by volunteering at vaccination clinics. During the summer, we also, during our spare time, we led the development of our patient, family, and caregiver partner and engagement strategy also by inviting other partners from across sectors to participate and co-design the content. We incorporate feedback from core partners to finalize the strategy. Final version was endorsed by core partners and was submitted to the Ministry of Health. There were over 20 initiatives and projects at one time in our OHT, of which 15 of them are still current, ongoing. We support all of the key North York Toronto Health Partner initiatives. We, as cross-learning opportunities is in our strategic plan, we actively participate in other forums. Co-design and collaboration are guiding principles, and co-design is the core to all our work. We initiate co-design learning that was led by our member, Kaileah. I'm handing over challenges to Leela.
Thanks, Kim. My colleagues shared North York Toronto Health Partners' success in responding to the vaccine initiative. However, this prevented us from focusing on critical issues of governance and the decision-making framework. This has had a huge impact. We do not have the supports needed for PCHC sustainability, recruitment, or training. Our members include caregivers who needed to take time off to address personal issues after they were matched to projects. We do not have dedicated resource to recruit and manage the relationship with participants who reflect the diversity of North York. This includes youth. We need to use different strategies to get feedback from our community. This cannot continue to be ad hoc, and it cannot be tokenism. As new members are recruited, we do not have training to enable them to participate fully to challenge the status quo. Some of our members are not comfortable challenging processes that are not inclusive, given the power imbalance. There were times when our members had to actively seek out partners for initiatives such as the engagement strategy and the equity versus equality issue in the patient declaration of values. Next slide. We have identified a lack of capacity in all areas, the PCHC, backbone, and partners. We do not have the resources to match to priorities based on an opportunistic approach and are stretched too thin. Burnout, frustration of volunteers is a real issue. Our focus will again shift to the COVID vaccine that has not yet been built into our work plan to ensure that other priorities are not left behind. This is concerning because if we don't, how do we keep the commitment, the momentum on fundamental needs such as governance, decision-making, community engagement, and embedding the equity framework? And at the same time, have transparent communication to keep everyone informed. Thanks. Over to you, Rivka.
Thanks, Leela. Moving forward, keeping our challenges in mind, our next steps are to maintain the flexibility we demonstrated during COVID to evolve and adapt with the North York Toronto Health Partners as priorities change. We will work with the NYTHP to implement our engagement strategy, which was outlined earlier in this presentation, and embody the ministry's patient, family, and caregiver declaration of values. As representatives on various committees, we will continue our work to operationalize communication strategies, both within and outside the OHT. We will continue to give voice from a patient and caregiver perspective on the governance structure and decision-making framework to encourage greater transparency. And finally, we need to build capacity and expand our membership through a successful recruitment campaign. We will do this using the NYTHP Health Equity Framework to inform our approach and develop training package materials. Our goal is to expand our council and network reflecting the diversity in our community. To this end, if you or someone you know has lived experience with the healthcare system in North York, we want to hear from you. Please contact us by email, nythp@nygh.on.ca. We want your help. Thank you.
Truly was a fascinating view and insight into the Patient and Family Health Council. So please come into the chat. We have a few questions that have started out. Be interested in your reflections, and we're going to bring some of the members online. And just before we do that, I've got one question that I'd be interested in seeing from the audience, which is your involvement in your OHT with patients and family. How would you describe the degree of patient and family involvement in your OHT? Do you just keep them informed? They're regularly consulting with them, involving them in the planning. Would you say that you're really collaborating in the decision-making? Or perhaps some are even saying that you would empower patients and families and follow their advice. We have 225 people online right now. I'm looking for a good response to this question here to get a sense of the participants. How you would describe your involvement in your OHT. Just a few more seconds. And 5, 3, 1. I could still see someone coming in, but we're going to close it off and share out the results so that everybody can see that there is a range of involvement. Fortunately, tipping to the involving patients in the family in the OHT planning. Second to that would be truly collaborating. So that's good to see, but there are also some OHTs that are really just have less involvement from patients, family, and representatives. So thank you. I'm going to take down the screen now so we can see each other, and hopefully we can come online. I see that there are a couple of items that came in on that in the questions, and I look forward to hearing. So one of the first ones here was really around this question about resources, and that came up. Ron mentioned it, and then again afterwards, I know it came up with Leela's comments. And so I'd be interested, I don't know, Wendy, why don't we could start with you, and then maybe Judy, and then come back around to others. What do you think about that? What does it really mean to have insufficient resources?
I think it's, we love the OHT team being very engaging, and they involve us. And our desire is to be more involved, but I think not having enough time and give you the sense of, my goodness, I'm gonna miss out on this. I wouldn't know what else is going on. Because I think that desire is not differ from beginning to now, but the amount of work actually is more intensive, but because now they engage us even earlier. And they are even engaging us at a proposal stage. As much as we like that, I think this is where we're saying there is the lack of resources to do all the things we want to do. And we're hoping to, we're even putting a recruit message today. So we're shameless right now, wanting to grow our team because it's a valuable work that we do want to support.
Anything to add to that, Judy? From your perspective, I think that was a pretty good summary.
No, as usual, Wendy did a great job. We all do enjoy being part of the work of the OHT, and we want to give it our full commitment. But very often, even trying to be on different working groups, there's conflicts between the meetings, and we can't be everywhere. So more people involved would be great. We did, as was mentioned, we did have a few more, but due to personal commitments, they had to step back a bit, and we're looking forward to having them back because they were very good.
Yeah, and Judy, I might just ask, do you have you thought about recruitment strategies for new members? And I'll bring this over to Emily and Ivy after as well.
We're just working our way through that now, and how is the best way to do that. With the pandemic, it was a little more difficult to get out and connect with people. We did get Rivka through recruitment, but that was before the pandemic. And I think the others that have stepped back were also pre-pandemic. We are putting things together, trying to get a good recruitment, but trying not just to get anybody. We want to get a good diversity representative of the population that we serve. So it's not just, any come one, come all. It's we're very targeted in trying to fill our members.
I think we have taken the approach to reach out to our partners PFAC group, and I think there's a lot of advantage having that network built up. And because that means our network is extending into different organizations, PFAC group. At the same time, there's a lot of work we've done with the vaccine rollout. We have reached out to the community, and there are ambassadors in the community. I think the struggle is to have resources. We know what we need to do. I think it's more on, can we have the resources and focus our energy to recruit? Because we don't think it's realistic to recruit, by diversity type, because we need to go to the group where the voice is heard rather than, pull people. So we have to find a creative way of doing our community engagement.
Yeah, and I think I've also very much to emphasize your point about really heard your interest and efforts in the demographics, the socio-demographics, the ethnicity representation in your OHT, and that you bring that to the table. I don't know, Ivy, Emily, how does this affect your strategies in supporting the patient family team as they go forward? Because the demand is on both sides. They call on you to say we need to be everywhere, and at the same time, it adds, obviously the same people can't be everywhere. So.
I'm happy to start, but Emily really is our backbone lead supporting our Patient and Caregiver Health Council. So I imagine she'll have lots of thoughts on this as well. I think we are in a very unique we're in a very unique time right now, given where we're at, particularly in the pandemic. And it is quite unusual where OHTs, although we were pretty new, I would say, in terms of our development, we're in the first cohort, but still feels very new, that we were then, of course, very quickly asked to pitch in the pandemic. So in the first phase, that would have been supporting long-term care retirement homes. In the next phase, of course, now with the vaccinations. So it has meant quite I would say quite a pull away from some of the more kind of, traditional OHT pieces of work. So the governance was mentioned and kind of our, our key initiatives and things. Amazingly, we sort of managed to do it all, but I think we're starting to feel that maybe 2 years into the pandemic. So certainly I would say, Emily, myself, others on the backbone are also feeling this strain and hoping for some relief shortly. And I think the other thing interesting, I think where we're at, you may have seen just from that presentation and from hearing, Wendy and Judy speak, they really are very much embedded with us including alongside us for all the challenging times that we've been through together. So it does feel a little bit like a team effort, although our team is tired. And so I think that's also something that we're, definitely all of us are sort of reflecting on in terms of what does that mean going forward. We've learned so much. Resources are unlikely to be resolved quickly. So I think that's something where we are now taking a bit of that time to reflect, look at what we would want to do. We're a very ambitious bunch, as you may have been able to tell, but of course needing to be realistic as well in terms of what we can really bite off and take forward, and making sure we're sort of staying together, through all of those steps, and making sure we're working together on how we prioritize, how we look at sequencing some of our work to make sure that we're all still able to keep up with this, with all the things that we would ideally like to do, maybe take a little longer than we thought, but we're going to get there.
Emily, just before, maybe I think actually I'll put a slightly different question to you, because I do see you do a lot of support to this council, helping them with their presentations, taking notes, providing that ongoing feedback. What would you say was one thing you've learned that you didn't expect to learn as being support to this team?
Great question, Walter. I feel like I learn from this team every time I engage with them. The learning is continuous. They're such an incredible bunch, and they just challenge us to think differently. And I think I always message Ivy after the meeting, like, wow, that went in a totally different direction. They inspired us to think differently and approach challenges. So I think it's just how much they add value to the work, and it's worth taking the co-design approach. We use collective impact as our model of working together, and I think that really contributes to our success. And our Patient and Caregiver Health Council group is amazing. Well,
thank you very much. And thanks so much for coming today and sharing with us your experiences in the North York Toronto health team. We're going to move along and hear now from the Greater Hamilton Health Network, and I'm really looking forward to this little chat. Jeff Wingard and Melissa McCallum, and Gaya is going to help with our introduction here. So Gaya, maybe you can come on and we'll hear your view of these members.
Okay, thank you, Walter. Can everyone see and hear me?
We can hear you.
Okay, well, that's a start, because I'm only seeing you, Walter, but I'm going to go ahead anyway. So the Greater, there I am. So the Greater Hamilton Health Network is a rather unique team. They had a bit of a late start compared to others in their cohort. So they had originally decided to focus on people with multiple chronic conditions, mental health and addictions, and then the pandemic struck, right? And so they changed tack and decided to focus instead on congregate settings. So things like residential care facilities, women's homelessness, retirement homes, and long-term care homes. So running through all these populations was really the thread of equity. So they set up an EDI committee, they hired an equity manager, and they really put a lot of work into an equity report. They did a lot of consultation for it, and it was recently released. A lot of effort has also gone into patient and family engagement. Now, this was a team that originally actually did not want to have a separate patient and family advisory council at the get-go, right? Its partnership council is actually led by 2 patient partners, and these 2 were also the lead signatories of their OHT application, but the patient and family partners, they preferred to be actually embedded across all the various working groups and committees, rather than actually sort of congregating in a standalone council. And it is really only more recently that they've come together in an organized way, but a lot of work has already been done. They've sort of formally figured out their role, their responsibilities, their values, principles, and so on. So similarly, coming together as an OHT has provided an opportunity for primary care as well to organize for the first time really in Hamilton. And a good chunk of time and effort has been put into figuring out governance structures for both primary care and the OHT as a whole. And Melissa and Jeff will be telling you a bit more about this. So this OHT, and technically really it's, perhaps the only OHT that's not an OHT. It is, after all, the Greater Hamilton Health Network. It has a history of doing integrated care, right? So, it was a pioneer in bundle care in the province, as many of you know, and it's really taking a slow and thoughtful approach to OHT building. So a lot of time is being spent on making sure everyone who needs to be included is included, on trying to really understand their populations of interest before actually going out and redesigning care for them. So a lot of good things. And I'm saying this not only because Jeff here has promised me $10 for every positive statement I make about this team, but because it really does seem that they're sort of thinking long-term and they're trying to build something that will last. So thank you, Melissa and Jeff, for letting me visit with you for the past 7 months. It has truly been a pleasure. Over to you.
Thank you, Gaya, and thanks everyone for having us. My name is Melissa McCallum, and I am the director of the Greater Hamilton Health Network, and I am joined by Jeff, my colleague, and we're going to be talking about our governance work specifically. Next slide, please, Walter. Just to add a bit to the background that Gaya had just provided, the Greater Hamilton Health Network is a very diverse group of stakeholders. We started out as the Hamilton Health Team in 2019 when we put in our OHT application. We're very lucky to have very strong partnerships and stakeholders that include very large acute care hospitals, municipalities, public health, primary care, community providers, home and community care, and many others that not listed on this slide here. We were approved during the first round of OHT approvals in November of 2019. Fast forward over to 2021, as we did, like many others, advance our work more through the COVID response through the pandemic. In 2021, we were asked to fully incorporate our full attributed population, which actually does include the neighboring communities of Haldimand and Niagara Northwest, giving us an attributed approximate population of 600,000. Because of this, we actually underwent a full branding and name change to reflect our full geography and are happy to be now the Greater Hamilton Health Network, just to include everyone that's part of our OHT, because it really is more than Hamilton proper. Next slide, please, Walter. So today we're going to be talking about governance. Next slide. And, we really set out on a very ambitious governance path earlier in this year. And we really wanted to put more rigor and structure around our OHT, and really saw that there was 2 main areas to start this work. The first was the overall structure of the entire network. We chose a path to incorporation for this route, and Jeff will be talking a little bit more about that. And then we also looked at primary care, looking at the structure of primary care within Hamilton, Haldimand, and Niagara Northwest. And really, this was a path to unify our primary care voices and ensure that they were strategic leaders in our OHT development and collaboration projects. And I'm going to talk about primary care here first. Next slide, Walter. So just a quick little landscape of primary care in the GHHN. Hamilton is actually home to 2 very large family health teams that cover about 60% of the population in Hamilton. Haldimand is also home to a large multi-site family health team, and Niagara Northwest, a smaller subset of Niagara's population, include some fits and foes, but no solo physicians. So we have I would say, the luxury of having not as many solo physicians as some of the other OHT areas. So how could we capitalize on the fact that many of these physicians are part of large family health teams already connected to our other partners? I'll say that during COVID, our primary care came together in kind of a town hall fashion where they met almost once a week to go through COVID activities and, calls to action. So we really wanted to capitalize on that group, which saw hundreds of family docs logging on each week to learn more about the COVID response and be more part of the response. So how could we capitalize on that engagement and keep the momentum going? So we talked a little bit in April with our large town hall group of primary care about whether or not it was the time to actually put some more structure and purpose around coming together as a sector, and they all agreed. So why did we want to put more structure around primary care? Well, the purpose is here. It was to promote improved and seamless care for our patients. We really wanted to foster the development of a population approach to care. We wanted to encourage innovation in primary care practice, and we saw so much innovation through COVID and calls to action and primary care stepping up. So how could we advance that? But most importantly, we wanted to create a forum where the voice of primary care was active and involved in health system planning and design for our OHT. And we all know, I'm sure, sitting around the OHT tables, that integrated care is really only successful when we have primary care as part of that planning. So we wanted to make sure that we had a strategy to embed this everywhere. Next slide, please. So just a quick timeline of the work that we underwent this year. In April, we introduced the concept of governance work and gained feedback from the larger primary care group. During the summer of 2021, we did an expression of interest for smaller governance working groups with our physicians to understand what kind of model, what would make sense to them, and what it would look like moving forward. We formalized a draft structure in September. We ratified that with the larger primary care group. In October of 2021, we had an open expression of interest to join our leadership and executive groups for primary care. And here towards the end of November, we have just finalized the leadership and executive membership to move forward. This is the form of what we chose as our structure to move forward with primary care. We first are going to start with a larger leadership group. And again, this was an open expression of interest from primary care. And I'm talking about those that provide primary care. We had expressions of interest from midwives, from pharmacists, those that were connected to a primary care model. We're actually looking at about 10 to 15 members that will be a reference group for our OHT. This group will feed into a smaller, more nimble executive group, which is about 4 to 5 members. Again, expression of interest for some open spots, but we also included our primary care leads as part of our OHT for the last few years to ensure that continuum of leadership was moving forward. We also knew that it was very important to attach senior level project management support to these groups that would provide logistical and policy support, but also be a link to national, provincial primary care groups to ensure that all messaging was staying within our OHT and that they had the administrative support to run these groups. So really happy to say that this is our actual structure for primary care. It took a few months to get to, but really happy to say that we're at the kind of end of the structure making process, and we are starting to meet and to understand how we're going to embed primary care's voice in all that our OHT does. We are very lucky that we have primary care in all of our working groups across OHT, and in many forms, they are our leads. So that is a really important link between our strategic planning and the primary care community. But now they have a complete and direct link to our executive council at our OHT, and we're really looking forward to moving this structure forward. I think I did see a question about whether or not we're engaging patients and families. And yes, we are. We currently have a call out for 2 patient advisors to sit at our primary care leadership group. So we'll be incorporating that voice as well. And maybe I'll just pass it over to Jeff to talk about the next stream of work, which is the governance of our entire network.
Thanks, Melissa. I want to assure everyone that I normally dress like a consummate professional, but today I wanted to start with just a little story of this baseball cap that I'm wearing. This is a baseball cap that I was listening to North York's presentation, and they talked about the fun and support that kind of has to go along with this work. And one of our physician leads See, Melissa's got one too. Melissa, one of our physician leads, is an avid duck hunter. And one of his duck hunter buddies is a hat maker. And our physician leader had a bunch of these hats that say COVID Buster on them, made for a bunch of the Greater Hamilton Health Network leaders. And I'll tell you that wearing a baseball cap camouflage may look totally appropriate for me. It is outside the comfort zone of many of our members, but we all wore them. And it was, I think, one of the turning points in kind of extending the boundaries of our team to include fun, do some team building, and just all around kind of expanding, you know, how far out does this team reach? It was a good moment. I'll take the hat off now. Go ahead, Walter. So I want to talk about our incorporation path. I'm going to give a little bit of information around why we chose to go toward incorporation, the path that we took, and the membership and board structure, where we landed. So I must start by saying that we have maybe the most awesome transfer payment agency in the whole province, which is the Hamilton Family Health Team. So it is certainly not because we were unhappy with their services that we decided to incorporate. There were really three reasons that we wanted to incorporate. One was we really wanted to provide structure and accountability for our members, for the people who weren't members, and for the broader community around who's a member, who's not a member, who makes decisions, who doesn't make decisions. All of those questions have been circulating, and the incorporation process really helped us do that. We wanted to increase our autonomy in our operations. So things like procurement, things like hiring, service delivery. We want to be able to do those things. And while we are technically able to do those things through our partners, we felt that we would be able to do more with our own corporation. We also wanted to manage shared risk. I'm sure this is something that other health teams are struggling with. And when we come together to do shared projects, there is always a question around whose risk is this? What is the element of shared risk? And so that was one of the driving forces that we landed here. I'm going to talk a little bit about the next two bullets in the next slides. So Walter, you can go to the next one. So this is the critical path. The actual content of this is not super important. We started a year and a bit ago with some consultant work on what path we should take. We looked at different models, limited liability corporations, partnerships, nonprofit corporations, and we ended on a nonprofit corporation with the board of directors, pretty typical. We then embarked on because we didn't feel like we had a good enough handle on the equity, inclusion, and anti-racism piece of what we wanted to include in the governance. We did another 6 months of work on that, which concluded in June. And then we restruck a governance committee to do some additional work on the actual bylaws, manual, etc. So we have just finalized all of those documents and should be submitting those within the next couple of days. The message here is this took a long time. And I think one of the reasons that we've been successful is that we took a long time. We, a few years ago, decided to try and do this in one day and pull everybody together and hammer out an agreement, and we couldn't ever get there. What we found is that if we stretch it out over time, it gives people enough time to think and reflect and give feedback. Next slide, please. So I want to talk about membership, where we landed. So the members of the corporation are health or social service providers only. And we did put a bit of a box around who can be members. So organizations need to be incorporated with the board of directors, need to have been in existence for 5 years, good financial standing, and you see the rest of the criteria there. We decided that the members need to be non-voting, so the directors are the only voting members of the corporation. There are a number of reasons for that. One is that it allows us to manage the overall composite picture of the board. We do have a diversity matrix that we're laying over the formation of the board that I'll talk about in a minute, but it allows the board to kind of evaluate needs across the director's seats. So, and we also decided that we would have a very broad membership availability with relatively limited powers. So we decided that we could potentially in this model have lots and lots of members, which was helpful. Next slide, please. So there's a couple of qualifiers for there. We decided individuals cannot be members of the corporation. So individual physicians cannot be members of the corporation. Individual patients cannot be members of the corporation. We did create another mechanism to involve them. Any organization can be involved in the work of the Greater Hamilton Health Network projects. Do not have to be a member of the corporation to get information about us. Do not have to be a member of the corporation to be part of the projects. Organizations can still be part of our project agreements and all of that. So this is not exclusive. This is not an exclusive effort to keep people out. It is just more a financial mechanism. And this structure will take time to mature. So our board manual and bylaws are quite refined. It will take some time to get up to that level of functioning. I mean, as everybody knows, OHTs are still trying to kind of find, put all the pieces together to do the things that we would like to do, and that will take time to mature. Next slide, please. So the actual board of directors is a bit of a hybrid representational model. So we did go with sector representational seats. There are a number of stakeholder membership classes. So like, for example, long-term care is a membership class, home care is a membership class, hospitals are a membership class. So upon coming in, organizations declare their class of membership, and the class of membership will get to nominate a director or two, depending on the class, to the board of directors. There are 3 independent director spots that the board can appoint to fill skill vacancies to make sure that they have the set of skills that they want. And as I mentioned, there is a diversity and skills matrix that we're going to lay over that, the whole picture, to make sure that we have a board that looks like and understands and has the skills to work with our community. Next slide, please. You'll have these slides available to you, and this is just a breakdown of the seats that can nominate directors. So this is a bigger, many of you will say, boy, that's a big board for a smaller organization. So it's 18 seats, and that I would agree, it's a little bit bigger than we want. However, we did want to make sure that we had voices at the table. We've all the way along, we've said we will develop governance models that work and that are effective in the situation that we are in. And we feel that this is great for our current activities. You know, should the nature of our OHT change down the road and we are delivering funding or we are making different funding decisions, we can alter how we structure this. Next slide, please. So as I mentioned, individuals cannot be members of the corporation, but we certainly wanted to build in voices to our board and to our project management team. So there's 4 examples of that that we created. We have the ability to create more should we want to. The primary care council that Melissa just talked about will be one of those groups. Patient and Leadership Council will be one of those groups. We have a Health Equity Council that is made up of experts in equity across the community. And then we also have a group of Haldeman stakeholders. Each of these groups will receive project management support and will have a work plan that's kind of ongoing, and will report to the board of directors directly as a path. So these groups will allow us to have input from people individuals and groups that may not qualify for membership, but we know are super important to the analysis of how we deliver service. And I believe that's the conclusion of my slides. Happy to answer any questions that there may be.
Okay, so I think Eric had a question about how did you define the relationship between member boards, hospital, family health team, and so on, and this OHT board? How do you see the relationship evolving?
Great question. We did look at some different approaches to voting. We certainly discussed kind of a weighted voting system. We ended up saying that the current description of what we are doing as an OHT, so kind of collective projects looking at population health, didn't warrant any kind of weighted voting system, and we went with a one member, one vote system. We have two major hospital systems, two major primary care family health teams. They each get one vote, so that's 4 votes. But then we also have a number of other voting groups that will get a vote, so up to 18 voting members. So we feel that the one vote per organization is probably the most appropriate at this time. I will say that we always work toward consensus. To this point, we have not had to have contentious votes. Not that we won't, but it has not come to that. But all of the members have really landed on the one member, one vote.
Thank you, Jeff and Melissa. Over to you, Walter. I believe we have to move on in the interest of time.
Yeah, I think that's true. It was really an amazing, I think, overview. And I think it's really striking to me that you were thinking about governance of the OHT, but with the interest of really involving primary care and having them be integral members, that also needs to be organized. And that there's that organization and governance going on at the same time. So I think that's really, really great. Thanks so much. I see the chat's picking up a little bit. It's actually been a little quiet today. I've been wondering if people have the chat open because we've had quite a few people online. So do feel free. This is about sharing amongst our participants and not just hearing from some experiences. I'm going to turn it over now to Kaileah, who will introduce the Chatham Kent and our other Melissa today.
Sure, thanks, Walter. So I've had the pleasure of working with and watching Chatham Kent OHT develop over the last couple months, or several, I suppose. And while all OHTs are in development, I think what Chatham Kent has recently been able to accomplish is really going to set themselves up for success. So part of that is the strategic plan, which we'll be hearing about later today, but they also have set up processes and structures and are willing to revisit those as needed and have really strong patient and family engagement. So I think with a lot of evaluation work and strategic planning overall, there's an opportunity to create value just by engaging in the process. And I think that's something Chatham Kent OHT has done here by engaging stakeholders and partners in the iterative process. But I think also beyond that, now that they have the strategic plan and agreed upon it, it's not just a document that sits on the shelves, and you really see how it's foundational to the work of the OHT now and how it permeates the different pieces. For example, seeing it on meeting agenda items and seeing how they relate to the different objectives. So really strong work here on the strategic plan. And I'm with that, I'll turn it over for Melissa to give you an overview.
Great. Thank you so much, Kaileah, for that introduction. Walter, if you want to move to the next slide. So as Kaileah alluded to, I will be speaking to the strategic plan of the Chatham Kent Ontario Health Team, both in how it was established and then also talking about how our OHT has really embraced it and are growing through the work of the strategic plan. But first, on the next slide, I would like to say to the almost 200 people on the webinar, welcome to Chatham Kent. For those who are not aware of where we are located, Chatham Kent is a largely rural, but we do have one urban area in southwestern Ontario, located between Windsor and London on the 401. We are a community that is generally known for its agriculture, its large open spaces, and our connection to the water, as we are surrounded by more than one large lake, so Lake Erie and Lake St. Clair. Our OHT partnership includes 15 signatory partners, which comprise 17 organizations. And in the community of Chatham Kent, our population is about 105,000. So though that group is small, it really does cover all of the main healthcare services that you would expect within a community. And in addition to that, there are over 100 individual partners or organizations and stakeholders participating on our working groups or advisory councils. So we really do feel like as an OHT, we are strongly connected to our community here in Chatham Kent. Next slide. I've been in the role here for approximately 1 year. And during that time, I have been able to really think about the connection between the OHT and the community itself. And when I came into the role, you know, there was a lot of work being done thinking about what Chatham Kent as a health system wanted to be, or what we wanted to be as a community and an Ontario health team. And you can see from this image that we really do in many ways have our work cut out for us. So Chatham Kent is a community that has a tagline of "We grow for the world." There's lots of fresh fruit and vegetables accessible to us, but we consume less vegetables than the average Ontarian. We have higher rates of smoking, lower rates of education, higher rates of unemployment, higher rates of chronic disease, lower activity levels. We have a young and growing Indigenous population. And when we think about healthcare usage, we have higher rates of ED admission and admissions to our hospital, and higher opioid prescriptions compared to other areas of the province. So when we thought about what it was that we needed to do, we knew we needed a strategic plan that was very wide, that stretched really far, and in some ways inspired our community and inspired our partners to think about how we can work together to collectively improve the metrics that you see here on the slide. So the next slide outlines the timeline for how we established our strategic plan. We actually began this work in February of 2021, which was really right in the height of the COVID pandemic for our community, but we felt it was still important to start to plan that work. So we took, you know, the later winter and early spring days to think about doing some of that research, planning, and understanding. As we shifted into the spring, we did a significant amount of engagement on our strategic plan. Our councils were engaged, our Patient and Family Advisory Council was engaged. We did our internal engagement with all of the stakeholders in the OHT, and then we turned to the community to do external engagement. Following that engagement, we worked within the framework and the structure of our OHT to create our strategic plan, both our goals and objectives, and the actions, and assigning what the actions would be for each of those working groups. So in August, we were able to launch our strategic plan. On to the next slide, you will just see a couple examples of how we got really creative during a time of you know, uncertainty and digital-focused initiatives. When we established our plan, we hosted a community survey. We partnered with the municipality to do that. And the municipality in Chatham Kent has a Let's Talk page, Let's Talk CK. And that's where they would host a number of engagement initiatives, from budgets to community information sessions. And it's kind of known to be the place that you go to talk about things within the community. So through that partnership, we hosted a Let's Talk Health page. And we were able to have a formal survey and also have some big questions that were asked and able to be engaged with online. You can see in the bottom right there, we leveraged our vaccine clinic and we printed actual paper postcards that had the QR code, a phone number, and a link to the survey in both English and French, so that people could access it. And for those who wanted to participate non-digitally or kind of over the phone, they were able to get that information there. And we found that to be really effective, because something we noticed about the pandemic is, in addition to pandemic kind of being the talk on the news, there was lots of feedback and lots of opportunities to engage around healthcare. It was a very popular conversation to be having in the spring of 2021. So on the next slide, you can see a sum total of the cumulative efforts of our engagement. So over 90 hours of focus groups. We had over 1,700 survey respondents, which, as I mentioned, in our smaller community, we were quite happy with the results of that survey. And then through online tools and engagement sessions, we had almost 7,000 thoughts rated about our strategic plan. And so all of that really demonstrates the cumulative effort and how we aspired to have a community conversation about the strategic plan. So on the next slide, you can see the one-page result of our strat plan. You can see there are 5 pillars of our strat plan. The first is population health, with the goal to transform the healthcare journey for the CKOHT population. The second is health equity. We will achieve a system that is safe and equitable for everyone in Chatham Kent. The third speaks to maturity, about deepening and growing our partnerships to accelerate maturity. The fourth is community, always remembering our purpose, and we will be ready to tell our story. And the fifth is performance, which commits to be innovative and accountable in achieving health system performance in everything we do. And under each of these 5 pillars within our strategic plan, we have set ourselves 3 objectives that we will achieve that are in alignment with that pillar. And behind those objectives are action plans. And in the background, we're also working on metrics and a scorecard for our strategic plan. So it is a very in-depth strategic plan itself. Once this was launched, our OHT took a deep breath and said to ourselves, wow, this was great, but now we need to roll up our sleeves and do the work. So on the next slide, you can see how we really did start to embrace the strat plan. So what you see here, and sorry, the lines kind of look like they didn't transfer over quite right on the slide, but you can see this is the governance structure of the OHT. The 3 circles on the top right of your screen are our advisory councils. Our collaboration steering committee is our decision-making body. Underneath that is myself and the executive committee. And then below, you can see there are 5 squares, which represented the original 5 working groups of our OHT. And as a result of our strategic plan, we added 2 more working groups, one to support the work of BPSO under the pillar of performance, and one to support the establishment of a human resource working group under the pillar of maturity. So immediately upon the launch, I, as the executive lead, looked to my staff and created portfolios to respond to the 5 pillars of the strategic plan. And our working groups looked at their composition and identified which working groups needed to be amended or added in order to achieve the strategic plan. On the next slide, you can just see a small screenshot snip of how we hold ourselves accountable to the completion of the strat plan. So within each of our working groups and on our steering committee, we report on the actions of our strat plan. As you can see from the one page before, our strat plan is a broad strategic plan. Oftentimes strategic plans will either be very broad in scope or they'll very be specific with maybe 1 to 5 actions. Ours is a broad one. There are a total of 50 actions that need to be completed within the strat plan. So we have identified the working groups that are responsible, the organizations that are going to be taking a lead, and anticipated timelines so that we can track and hold ourselves accountable to how we will achieve the plan. This document in a bit more finessed form, not so much in the Excel format, but is published annually on our OHT webpage so that everybody who participated in the development of the plan is able to see our progress and identify how it is that we are working to achieve that plan. And then finally, I just want to speak to how we as an OHT have grown through the plan. So often people ask about our strat plan and align it to the TPA requirement of an OHT expansion plan. Our strategic plan is so much more than that. Certainly in the maturity column, we are looking at how we're going to deepen and grow our partnerships and expand as an OHT, but we've really set this strategic plan up as one that can be embraced by all healthcare organizations and social service organizations within the community of Chatham Kent. We've since had lots of excellent conversations with other OHT partner organizations in the middle of their strategic planning processes now, who've identified areas that they can take on a leadership approach. And at the Strategy and Performance Working Group, which has overseen this process, we've talked about how in the future, our strategic plans could potentially roll into one single OHT strat plan where everybody has a piece of a strategic plan. So further deepening our integration as a health system. Through the strategic plan, we've now leveraged that to establish our agendas, our intake forms, our evaluative frameworks, and make sure that what we are doing and what we're taking on as an OHT is in alignment with the strategic plan. This ranges from external opportunities, so when Ontario Health introduces a new initiative and we're evaluating how we want to be involved as an OHT, to internal initiatives when a new stakeholder has an idea that they would like to work with us or would like to suggest something, we then now have this benchmark of a strategic plan to say, is this initiative, which may or may not be on the strategic plan, in alignment with our goals, our times, and objectives? And if it's something brand new, what's the reason that it's coming up now rather than when we were planning for strat plan? So it really does help us to identify where it is we're going to put our time, energy, and dollars as an OHT. We also are using the strat plan to achieve the states of maturity that are outlined by the ministry for us. So there are those 8 indications of how OHTs will grow in their states of maturity. And as we work through this, we're leveraging our strat plan to say, if we do these activities, we know we're going to get closer to those 8 states of maturity. So it gives us something to focus on as the health system around us continues to ebb and flow. So I see there are lots of great questions that have been popping up through the session. I'm happy to answer them as they come through. And I think the last slide is really just our contact information. If you're looking for more details about our strat plan, we do have a whole page dedicated to it on our website, which is ckoht.ca.
Great, thanks, Melissa. I'll start out just by a comment there that this is a great example of how a strategic plan is operationalized. So I'll just echo that comment. There was a quick question just about some of your methods in terms of focus groups and if that was online or in person.
Yeah, so great question. Our focus groups we did entirely online because of the timing of them and what the current public health guidelines were around gathering. We leveraged Zoom platforms. And we held small focus groups. So for partners who were very involved with the OHT, who are a member or an active participant on our working groups, we had small focus groups, so less than 5 members per focus group. And for the broader community, we had a number of community engagement sessions, both by sector and for the broad community overall. So we leveraged many different styles, Kaileah.
Great. And then there's another question just about resources. So we got a sense a little bit of the timelines and how long it took, but just if you could comment on sort of the resources it took to make this happen.
Yeah, absolutely. So for the development of the strategic plan, we have a staff member who is an engagement and partnership specialist with the OHT in Chatham Kent. And she began working with us in April, and I would say the first 4 months of her work from April till the end of July were completely dedicated to the strat plan, at least 80% of her time. So it was an initiative that as an OHT, we decided we would take on and dedicate the resources for. But we do think that it was effort and resources that will pay dividends in the future in terms of the time dedication.
Great. I have a question just in terms of the timelines of the plan. So I believe you chose a 3-year timeline, and I think that's a challenge with lots of OHTs is sort of the push and pull of the importance of long-term planning and the challenges of the uncertainty and having resources for the short term. So I'm just wondering if you could speak to that a little bit and how you made that decision.
Yeah, absolutely. So when we first started, we were looking at whether or not we wanted to do an operational plan, so something that was in line with the TPA timeline, a long-term strategic plan, which would be a 5-year, or a short-term, so a 3-year plan. And by and large, the support from our OHT partners is that we wanted a midterm, like a 3-year strategic plan, for 2 reasons. One, we wanted to think beyond just what the deliverables are in the current fiscal year for our TPA. We think our TPA is very clear in terms of what the ministry is hoping for OHTs to achieve in the time that they have until March 2022 for us as our TPA end year. But with the COVID pandemic and with the change in potential governance or direction, we wanted to ensure that we had some long-term range, but we're able to pivot as necessary. So we kind of did the Goldilocks principle, right? Not too big, not too small, just right in terms of timeline. And ultimately, we are now looking at future strat plans. And as I said, how we could collaborate together. So we think that we've timed it well. And our partners are also starting to think about their own strat plans aligning with the end of our strat plan here in Chatham Kent.
Great. Walter, I believe you had a poll to launch on this.
Yeah, I do. I've got a poll. So I'd be interested in going out with everybody to hear about your where are you at in your strategic planning, and particularly the stage. So I'm interested in whether you're working from an original plan that you had at the time of your OHT application, or whether you've revised the plan since the application or are about to do that, and if we can aim to review it in the future. So really where you're at on here. So I'm going to launch this so we can hear from the people that are out there. Here we go. So where are you at? Are you working from your original strategic plan? And people are definitely, as much as people are quiet on the chat, they're definitely into the polls okay today. Maybe we should have had a whole bunch of poll chats to sponsor folks. So I see that people are coming in, so welcome. Okay, so it's slowing down a little bit. And so I'm going to leave it up for 2-3 more seconds. Okay. Can end the poll and share the results back out. So you can see here, actually, there's quite an array. A number, about just under 40%, are currently in that process or about to review and revise the strategic plans. I've seen this across a few, I think, but a good number still working from the originals. And then some, about 1 in 5, have already done a review or a revision, and a smaller number have that aim in their future. So that's quite interesting, I think. There's a really excellent question here about the strategic plan aligning with other partners' strategic plans. So I wonder, Melissa, if you could comment on that component, whether you were talk to other partners.
I was, yeah, absolutely. I was just kind of typing to Wendy some of the response, but when we were developing our strategic plan, actually, one of the questions in our focus groups within our partners were, what do you feel your organization's strengths are? And how do you think you can take a leadership role in moving our OHT forward? And through that question, many of our partners shared with us where they feel they excelled and what their organization was looking to contribute to the health system more broadly in the coming years. And we were able to integrate that into the strategic plan. And it flowed right through to appearing in our plan and then identifying who key leadership organizations and stakeholders could be. Now that our strat plan is launched, we have a bit of a different approach. We're going to the boards and to our partners when they're inviting us, which is becoming frequent and a good thing, and sharing with them the strategic plan, and then having a conversation about where their organization fits into it, or if they're in development of their plan, where their own plan can fit within the strat plan. So we're really trying to really grow together through the existence of our strat plan.
Thanks very much. The chat's really unusually quiet today. So I think we're going to come along to like other general questions in the chat for any of our panelists today around governance, around strategic planning, around patient-family involvement. Do you have questions of our panel? So I'll just put that out there and see if we come with any new thoughts or pieces coming into the chat. Remember to type into everyone. And I'm getting a message on my screen once or twice that says somebody might have put up a hand. I'm not sure we had that option before. We can't take people off mute here, to my knowledge, in the large webinar forum. And so I do ask for people to use the chat option. Waiting to see. Some people really commenting in around the timeliness of the strategic planning and now we have some people typing in, so that prompts me good. So I have a question. Some of the questions are not coming into everyone, so it's hard for us to see the ones that don't get sent to everyone. So there was a question, I think, around with the broad community engagement, Melissa, okay, you've answered this question. Survey identified about 60% of the participants knew about the OHT. That's actually an interesting question for all, because I've sat on some of the groups, and I know that some teams have just said, our OHT will have been known to the community. So 60% awareness of the OHT even if it's only among people who are coming into health system for encounters, it's still pretty good, I think. Here's a question from Anne. Melissa, are you using, or how are you using the strat plan for resource allocation, such as prioritizing projects? I think that's an excellent question from Anne Wojtak.
Yeah, it is a great question. And we have developed and are in the process of reviewing it with our strategy and performance working group, what we are calling an intake evaluation tool. So when there is a new initiative or initiative that requires funding resources, how the OHT can confirm its alignment within the strat plan and then identify if that is an initiative we will take on. In terms of the resource allocation and the project funding, just your question leads me to think maybe about some of our TPA funding. And as an OHT, we're starting to shift a bit from TPA funding, thinking about it funding projects, to really more of that backbone support. So rather than giving, $30,000 or $50,000 to achieve a small project, we're thinking, what are the backbone roles that our OHT needs to enable these projects to take place and to enable the collaboration for those initiatives to take place? So in some ways, we're starting to really think about our resource funding in different ways because of our strat plan as well.
Well, that's very interesting. Thank you. I'm going to ask you this question, but I'm going to come back also to Jeff and the other Melissa. Actually, I think the other one's gone off to chair a meeting, but Jeff is still here. And Wendy, one of our other panelists today, has asked if you could comment about the decision-making process about whether and how new initiatives fit or do not fit into the strategic plan. And I say Jeff because I think this is going to come back to how governance makes decisions as well. So first to you, Melissa, about how the decision-making process.
Yeah, so another good question, Wendy. I will say our strat plan is still young enough that we haven't yet had something come up that doesn't fit or is not directly in line with the work of the strategic plan. That being said, our consensus-based decision-making framework does put new initiatives, first going to strategy and performance working group to discuss them and to discuss their merit, and then from there, a recommendation going to our collaboration steering committee. If for whatever reason our collaboration steering committee cannot achieve a consensus, again, like Jeff had mentioned, it has not yet happened yet, but we know there could be difficult decisions on the horizon. Our escalation process actually, if we can't gain consensus, brings us to the advisory council of our chairs, which are the board chairs of all of the signatory partners of our OHT. But again, I think right now our strat plan is so new that there is a lot of energy and interest in advancing the plan itself. We haven't yet been introduced to any new ideas to evaluate their fit yet.
Okay, thanks. And Jeff?
Yeah, I really I like that conversation. It's interesting that Melissa actually stepped off because we're having a meeting with one of our secretariats around taking on some new initiatives. Our problem has not been that new initiatives don't fit in our strategic plan. It's that there's so many potential new initiatives and urgent initiatives, and it's a question of where can we best have an effect on these pressing issues. The thing is that our resources are limited and we can only take on so much. So I think the question becomes not does the issue not fit, but which are we going to prioritize? And that's a harder discussion, quite frankly. I think that we look to people on the front lines to give us some input on that. We do have those conversations with our executive council to help us make those decisions. But really, there is a judgment around where can we make the biggest difference on the issue that we're thinking about taking. But that one is a complicated one.
Well, thanks for that. So I think we're going to wind down a little bit. Just wanted to put out a couple pieces for everyone to be looking for. One is a paper that just came out at the beginning of health system transformation and health policy, how Ontario health teams are implementing change. Gaya led this piece of work, and it is open access available. I believe it's moved from corrected proof to final. And for those that are subscribers to Healthcare Quarterly, There's another paper. This one's behind their paywall, but you could contact us directly for copies if you're interested in this paper that looked at the current state of collaborative leadership from OHTs. And this is out in October's Healthcare Quarterly, so newly released. Up next, this webinar series, we are here every month on the 4th Tuesday of the month from 12 to 1:30. And we continue to have wide participation and lots of people online. We're up to about 225 today, and some people popped off after the 1 hour mark, which happens sometimes, but often doesn't. A new year, 2022. We are coming back. You've seen us talk at periodic times about population health management and population segmentation. We're going to do this with a view to CQIP indicators, which might be on the minds of some of the participants that are participating today. And we will have more stories from the field, and particularly interesting some of our other findings from the developmental evaluation that we've alluded to, bringing these stories forwards. What are some of the cross-cutting themes you'll hear from our team coming up in the new year? So with that, I'm going to wish everybody a wonderful, wonderful afternoon. We are all involved. Do follow us. We post anytime we're putting anything out, we post to Twitter. You can email us with any questions that you might have at oht.evaluation@utoronto. Please check out our evaluation website and subscribe on YouTube to get copies of these wonderful, wonderful presentations that we have. Thank you very much, and have a great day, everybody.